So next week, we're going to really kind of hone in a little bit more on this idea of treatment selection and sequencing, because it is so complicated now that we have so many options, which is certainly a good thing. So we'll start off with this polling question. What is a potential second-line treatment option for a patient with metastatic ER-positive, HER2-negative breast cancer who's progressed on a CDK4/6 inhibitor? A, elacestrant if mutant ESR1, B, fulvestrant everolimus, C, fulvestrant alpelisib, assuming PI3K mutant, or D, all of the above. Very nice, all of the above. So we'll get into some more of these details. So this is taking Aditya's algorithm and making it more complicated and maybe more complicated than people would like. But I think it goes to show you how complex this is. So if someone's had an upfront AI and CDK4/6, what are all the things we have to think about when trying to pick a drug for the next sequence therapy? And in my mind, there's a lot of different factors, right? You have to know if they've got a germline BRCA mutation. You have to know if they're PI3K mutant. You have to know if they have an ESR1 mutation. I think soon we're also going to have to know about PTEN and AKT alterations. And so I think those are key drivers. I think it's also clinical presentation, right? Is this someone who had a tiny bit of progression, doesn't have a lot of visceral disease, or is this someone whose like liver is exploding with cancer and you feel a bit more urgency to try to reduce that amount of disease? And so, I think there are a lot of factors that one has to think about when trying to make these decisions. And so you can see here how complicated it is. And we'll get into maybe why some of these directions were chosen based on particular alterations and based on particular clinical scenarios. So we'll start off first with PI3 kinase inhibitors. So a question for you all is, what percentage of metastatic hormone receptor positive breast cancer has a PIK3CA mutation? Is it A, 15%, B, 25%, C, 40%, or D, 50%? I think just important to kind of put this in context for how often this occurs. So the correct answer is about 40% of patients will have a PI3 kinase mutation. So I do keep that in mind because it is almost half of our patients who will have an alteration. So this is a commonly mutated pathway, and you can see it's complicated because there's a lot of other downstream signaling pathways beyond PI3K, right? There's AKT, there's PTEN, and so you are going to get this signaling cascade that is really stimulating growth of the cancer cell. And so clearly one really nice thing to think about is just turn it off. And so we originally saw data from SOLAR-1 showing the benefits of giving alpelisib in combination with fulvestrant, really leading to significant improvements in PFS. But the challenge with SOLAR-1 was that it was in a trial population that had not really seen prior CDK4/6 inhibition. So we did get data from the BYLieve study, which specifically looked at the efficacy of fulvestrant alpelisib in a post-CDK4/6 population. It had different arms, the first arm being in combination with fulvestrant, the second arm being in combination with letrozole, and then the third arm really allowed intervening therapy and even allowed the same endocrine backbone. So you could have even had prior fulvestrant to get on to arm C. And I think this is important because people may have received different endocrine backbones with their CDK4/6 inhibitor in the first line setting, and that can influence which endocrine backbone you're giving second line, and nice to have data with different choices here. And in essence, what you saw was that the PFS across these studies, across these arms, ranged between 5 to 7 months, depending on the cohort. And we know that if you looked at fulvestrant alone in a post-CDK4/6 setting, the PFS is usually just over 2 months. So I think this is suggesting that this combination does have robust efficacy in a post-CDK4/6 population, whether you use it with fulvestrant or an AI. It is, again, something that does seem to be quite efficacious. Obviously, this was not a randomized trial. It is single arms, but knowing historical control here, I think it is very reassuring to see this prolonged PFS. One of the challenges, though, with alpelisib is it does have high rates of high-grade hyperglycemia and rash, as well as diarrhea. And so there's been interest in seeing if there are other ways to attack this pathway and how the efficacy would play out. One agent that we've seen recent data from is capivasertib, which is an oral AKT inhibitor, which was studied in CAPItello-291 in a phase 3 study where patients who had progressed on endocrine therapy and could have progressed on a CDK4/6 inhibitor were randomized to get fulvestrant with or without capivasertib. They enrolled patients irrespective of biomarker alteration. And so here you can see that the PFS was to look both at the ITT population as well as the biomarker altered population, meaning people who had an AKT, P10, or PI3K mutation. And when you look at outcomes, you can see that adding capivasertib to the ITT population did result in a significant improvement in PFS with a hazard ratio of 0.6. You can see that this benefit is really seen across all the subgroups, even in patients who had received prior CDK4/6, as well as those patients with visceral metastases. So again, robust efficacy. One important thing to point out is that there were lower rates of hyperglycemia as well as rash with capivasertib relative to what we've seen with alpelisib, and it did allow patients who even could have known diabetes at baseline, which is different than SOLAR-1, where patients in that study had to have a hemoglobin A1C under 6.5. So it allowed, again, a broader population of patients that could have had underlying hyperglycemia and yet still saw a lower rate of hyperglycemia in the study. It does have diarrhea, which I think one does have to keep in mind, and certainly does have some hyperglycemia and rash. And so not without these toxicities, just less than we're accustomed to with alpelisib. So another choice to think about is there any role for continuing CDK4/6 inhibition beyond progression? We certainly know it is standard in the upfront setting, but what about if someone progresses on it? Could you swap out the endocrine backbone and continue a CDK4/6? So here the question is just yes, no, maybe, or I don't know. I'm curious to see what you all think of this answer. So most people said yes here. And so I think this is a controversial question, so I don't think there's a right or wrong answer to this. But we'll kind of review what some of the data is. So originally, actually, Dr. Bardia's group had shown that there was some signal of activity for this idea of continuing a CDK4/6 inhibitor beyond progression. So I think what this case series was interesting to see is they saw a PFS of a little over 5 months in people who were getting endocrine therapy with the BEMA if they had had prior palbo-ribo. In this, again, knowing that endocrine monotherapy here would have had a lower PFS, certainly suggested that there was a signal that this idea of continuing CDK4/6 inhibitors beyond progression had activity. But now we've seen some randomized data. So this is the PACE study, which was run by my colleague, Erica Mayer, where they were sort of asking the question, can you use palbo post-palbo and just swap the upfront AI for fulvestrant at time of progression? So people were randomized after progression on AI CDK to get fulvestrant with or without palbo. And there was also a third sort of exploratory arm of adding a PD-L1 inhibitor to fulvestrant to palbo, with the idea being that there's some preclinical data to suggest synergistic activity with CDK and checkpoint inhibition. And so this was explored as a third arm in the study. Unfortunately, this study did not show benefit of palbo post-palbo. One potential rationale was that these arms were a bit imbalanced, with a lot more endocrine sensitive patients in the fulvestrant arm relative to the fulvestrant palbo arm, sort of biasing the fulvestrant arm to performing very well. Because here, when you look at the PFS for the fulvestrant, it's almost 5 months, which is much higher than we typically see with fulvestrant in a post-CDK4/6 setting. So again, may have been due to patient selection here and some imbalances with the arm. And you can see really no difference in PFS with the addition of palbo to the fulvestrant with a PFS of 4.6 months. And while the study was not robustly powered to look at the difference with adding the avelumab from an exploratory standpoint, it does look numerically a lot better when you added the immunotherapy here, the PFS of 8 months. And so I do think that third arm would need further evaluation and not something we would standardly recommend at this time, but certainly does seem to be of interest. And then we saw data just a couple weeks ago at ASCO really suggesting what PACE found was that there also was no benefit to palbo post-palbo. This was a Palmyra study, very similar design to PACE, accepting just 2 arms and also allowed choice of endocrine backbone here. And here again, no improvement in PFS by adding palbo to your endocrine therapy in a post-palbo setting. However, this does stand in contrast to what we've seen from the MAINTAIN study, where we did see that there was a benefit for ribo post-palbo in a randomized phase 2. So I think given the negative palbo data and the positive ribo data in MAINTAIN, we really do need more definitive data. And I think we're hoping to see that in post-MONARCH, which is a phase 3 study that is specifically looking at this question, but looking at it with use of abemaciclib as the post-CDK agent. So that study has actually been fully enrolled. So we'll see when we get data from that. There's also this interesting combination in ELAINE-3 looking at lasofoxifene in combination with abema in the ESR1 mutant population. So that will be really important. And then EMBER-3 will actually look at the combination of the Lilly oral SERD imlunestrant, either alone or with abemaciclib in a post-CDK setting, comparing it to endocrine therapy alone. So I think more to come here. So I think at this time, I would say it's not standard to continue CDK4/6 beyond progression. However, I could see in a very select patient doing this either with ribociclib or abemaciclib if they hadn't seen either of those agents first line and they just had a teeny tiny bit of progression and not a lot of visceral disease, it may be something that comes up. So I think you can see there's a lot of choices here, as we showed. Dr. Bardia very nicely reviewed the data about elacestrant and the ESR1 mutants. But what about now we have data we've seen for PI3 kinase inhibitors. Hopefully soon we'll see capivasertib approval for AKT inhibition. We didn't talk about mTOR inhibition with everolimus. There's some data about continuation of CDK4/6 beyond progression. And so I think quite complicated. Aditya, I'll turn to you. How have you been thinking about this space? And, are you using, for example, fulvestrant, everolimus in some patients, or what are you doing for patients in the post-CDK setting?
Yeah, no, it's a good question. And if we do plasma-based genotyping and there are no actionable alterations, the challenge is, should you do fulvestrant everolimus? Should you do fulvestrant plus a CDK4/6 inhibitor? In general, I've not been using fulvestrant monotherapy, given what we've seen with multiple clinical trials in terms of limited activity in that setting. Fulvestrant everolimus is a combination that I'm fairly comfortable with. With the use of mouthwash these days, we don't see much mucositis. And from a biology perspective, it does address the PI3 kinase pathway. And I'm looking forward to the approval of capivasertib because that'll provide an additional option in this space.
I think that's an excellent point. I guess we did have a couple questions about how do CDK4/6 inhibitors perform. And one question was with regards to patients who have ESR1 mutation, and another with regards to PI3K mutations. Certainly, we know in the first line setting, if someone has a PIK3CA mutation or ESR1 mutation, that the relative benefit that they derive from CDK4/6 inhibitor therapy by hazard ratio is similar to what we see for PI3K wild type or ESR1 wild type, mutant patients. So again, their benefits to CDK4/6 inhibition are the same, and so shouldn't influence your first line therapy for choice of use of CDK4/6 inhibitor treatment in that setting. I guess one question to twist it is, we sort of brought this to Aditya, if someone has ESR1 and PI3K, if you were sort of putting efficacy side by side, now that we've seen the BYLieve data, if you were to ask what's the PFS in an ESR1 mutant, PI3K mutant patient, they actually did present that from BYLieve, and we didn't show that here, but the PFS was, almost 5 months. And so that is a little different, certainly, than we've seen as a median PFS with elacestrant. But again, we don't have the data from EMERALD yet for how the PI3K mutant patients did. So Aditya, I don't know if you have more to share on that and when we may see some additional genomic data from EMERALD.
Yeah, no, absolutely. I think that's an important question. If a patient has ESR1 PIK3CA, we need biomarker results from EMERALD and ideally from SOLAR-1 as well, because SOLAR-1 looked at PIK3CA, but also had ESR1 mutant results. So looking at how the patients did in the phase 3 trial, I think would be critical. So hopefully over the next year or so, we'll start to see biomarker results from these studies because it'll help address this data gap.
Well, thank you.